Okay, welcome everybody. Welcome to this first iteration of the new platform on Teams. One thing I do need to address is that I did say in my email to all of you that we're going to be going through the chat. Excuse me. However, it actually is the Q&A, and I'm going to be moderating that as I had mentioned. So if you have any questions throughout the presentation, just put it in the Q&A and we'll move forward from there. We may wait until the end, depending on if it's an immediate ask for the information being presented at that time. But other than that, welcome. And I'm going to turn it over to Dr. Sieger and she can introduce herself.
Great, thanks, Darcy. Hello, everyone. Good afternoon. My name is Margaret Lloyd Sieger. I am an associate professor at the University of Kansas in the School of Medicine. But before being at KUMC, I was at UConn in the School of Social Work. So have some deep ties to the wonderful state of Connecticut. And we're going to be talking about some of this in the context of Connecticut policy and how to support families in Connecticut specifically. I love Connecticut. I was just telling other folks that we were back for a wedding this past weekend, and it was incredible. We stayed in Bloomfield on our farm, AUER farm. They have Airbnbs. If you are ever looking for a staycation in Connecticut and you want to like wake up and play with the goats, I highly recommend it. It was amazing. My email address is here. It's a great way to contact me. I also included a QR code to my highly niche TikTok. So if you're someone who, cares about this stuff so much that you want to learn about it in your free time, I'd love to interact with you. I post stuff just about current research on substance use, pregnancy, and parenting. So yeah, major nerd alert here. It's a really nice way to So today I'm going to be talking about MAT and pregnancy. I'm going to use the term MAT and MOUD throughout the presentation, probably MAT. It kind of rolls off the tongue a little easier, but I mean the same thing. I think most people here are in the field, so you know the difference, but for anyone who doesn't, medication assisted treatment, aka MAT, is an older term. And it's also more broad. MOUD stands for medication for opioid use disorder and is more specific to the types of MAT that specifically target opioid use disorder. That's what we're going to focus on today. There are, of course, other types of MAT, everything from a nicotine patch to methadone would be considered forms of MAT. So, but today we're going to be pretty much focusing on MAT for opioid use disorder. Like it was said, we have a Q&A going. So if you have questions, please put them in the Q&A. If they are clarifying questions, meaning you just want me to go a little bit deeper on something that's on the slide, or need definition explained or something like that, we'll do that in real time. But we're also going to have time at the end of the session to do more in-depth questions that kind of cut across topics. And then I guess a little more in terms of an introduction, like I said, I was at UConn in the School of Social Work. I have been researching substance use, pregnancy, parenting, child welfare since my doctoral program. And before that, I worked in the legal field. I'm a person in long-term recovery. I just celebrated 15 years in recovery. So I have a personal passion. I am, deeply connected to people in recovery. I celebrate all pathways of recovery. And I also research this. And a lot of my focus is on, obviously, families where there's a substance use disorder and how systems, including the child welfare system, can support families to outcomes. Okay, so we're going to start just talking about the prevalence of substance use and pregnancy, some of the risks, why we care about it, why child welfare cares about it. Then we're going to get specifically into MAT. Like I said, we're going to be focusing on medications for opioid use disorder, mainly methadone, buprenorphine, when each is best, what are the risks, how to help patients navigate preferences, treatment planning. I'm going to talk a little bit about tapering and unplanned pregnancies and helping do some pre-pregnancy counseling with patients. We're going to talk about neonatal abstinence syndrome. We're going to talk about preparing moms for NAS. And then I'm going to spend a little bit of time talking about family care plans, which is Connecticut's strategy for equipping parents with necessary supports to navigate the transition from person in recovery to parent recovery. Okay, so start with some statistics. This is a tricky thing to measure, because when we talk about substance use in pregnancy, do we mean like one hit on a bowl being passed around at a party? Do we mean one sip of champagne at a wedding? Or do we mean someone who has a severe untreated use disorder using multiple times a day, every day? The other issue is how we measure it. Do we ask people to self-report? It's obviously a very stigmatized behavior. And so how honest are people versus using something like toxicology, which has its own limitations in terms of what is measured, how long it's measured, et cetera. But one of the data sets that researchers often rely on is called the National Survey on Drug Use and Health. And it is a self-report survey. It's nationally representative, which is one of the reasons researchers really love it. Again, one of the problems is like, well, if you collect toxicology from a specific hospital, that is going to tell us about what's happening at that hospital, but not about what's happening across the country. So the National Survey on Drug Use and Health uses, again, a population sampling strategy. It only talks to about 600 or 700 pregnant women in a given year, but uses a weighting WEIGHT weighting strategy to basically extrapolate those findings to the population as a whole. And so here we see different years in the different colors of bars, and then we have the different types of substance use that the National Survey measures. Illicit drug use. Illicit is, of course, kind of a moralized term, but I think it's meant to mean illegal drug use. They specifically measure within illegal drug use. They still count cannabis as an illegal drug, specifically measure opioids, any type of opioid, which would include medications for opioid use disorder, and then alcohol. They measure a bunch of other stuff. It's an incredibly long survey, but I'm just going to be focusing on these right now for a couple reasons. One, we see that there was a recent peak. So people talked a lot about, here's COVID, this dark blue bar, 2021, 2022. We are aware of the fact that there was an increase in substance use across the board, across the whole population, and that included pregnant people during COVID. So we see this big jump from 2019 to 2020 in terms of drug use, big jump primarily, of course, driven by cannabis use, but we also see an increase in alcohol use in pregnancy during that time. The peak, however, was not in 2020 or even in 2021. It was in 2022. In 2022, over 9.5% of pregnant people surveyed self-reported using some type of drug in pregnancy. Close to 8% of that were cannabis users. This could include people who, again, are using one drug, multiple drugs. We could get deep in the weeds on this. We're not going to for the sake of time. But as you can see, that first of all, there were a lot of people using substances during pregnancy. The majority of them were cannabis. Alcohol use, though, is always the most common substance used in pregnancy. The rates of persistence of these different substances, though, vary, as do the rates of substance use disorder, which, when we're considering risks to the development of the fetus and potential risks in terms of child safety after the baby is born, have more to do with the presence of a substance use disorder than they do simple substance use. So then the last point I'll make here is that we saw a big decline from 2022 to 2023 in terms of illegal drug use, cannabis use, opioid use, and alcohol. So this potentially suggests that the sort of increase that happened around COVID, the trauma of COVID, we've come back to kind of pre-COVID levels. Now, I mentioned the importance of considering substance use versus substance use disorder, because this has big implications for thinking about safety planning, thinking about what those concurrent psychosocial needs are going to be. And so we'll see that the rates of use disorder vary a lot depending on the type of substance. This is also, again, helping us think about safety planning kind of from a child welfare perspective. Currently in Connecticut, hospitals have to submit a notification to DCF. It's de-identified. It doesn't include any identifying information on the parent or child if there's any substance use in pregnancy identified during pregnancy. But as we can see here, the rates of substance use disorder among alcohol and cannabis much more likely to have a mild substance use disorder, which is much less likely to adversely impact parenting compared to a moderate or severe substance use disorder. Moderate and severe would align with our old DSM criteria of substance abuse and substance dependence. So we didn't even have a diagnosis for a mild substance use disorder until the DSM-5. But with these other drugs, cocaine, heroin, meth, prescription pain relievers, non-prescription pain relievers, if someone is using these substances in pregnancy, they have a moderate or severe substance use disorder, most likely. There's no one who has a mild substance use disorder involving cocaine during pregnancy. So while you can with alcohol or cannabis, and then, treatment's going to look different when it's some of these, quote, harder drugs, it's much more likely to be a severe use disorder. So I'm going to talk about nicotine in pregnancy because it's also very commonly used relative to these other substances and can have adverse effects on the fetus. It's also challenging to treat, and I'll tell you why in a moment. So we know that about 5 to 7% of pregnant women smoke. Before becoming pregnant, 10 to 15% of women smoke. And so about half of those women persist in pregnancy. The other half are able to quit pretty much as soon as they find out they're pregnant, but the other half persist. The reason we care is because nicotine restricts oxygen to the fetus, which can lead to low birth weight and preterm birth. We want babies to be big and fully cooked when they're born. There are all sorts of longer-term developmental consequences that can happen if a baby is born too early or small for their gestational age or low birth weight. Obviously, none of these things are going to result in bad outcomes for everyone who experiences them. It just increases risk. And from a public health perspective, we want to decrease population risk. So the reason nicotine is tricky is because it's not the tobacco, it's not the vape that's the problem necessarily, it's the nicotine. And the best match we have for nicotine is nicotine replacement therapy, meaning a patch, gum, etc. There are also some medications that are used that are not nicotine replacement therapy, but they're not indicated in pregnancy. So this would include Wellbutrin, Chantix, those are the name brands. Although these approaches are completely safe after the baby is born, depending on breastfeeding status, which is important because smoking is a significant risk factor for SIDS, sudden infant death syndrome. It's also called SUID, sudden unexplained infant death. So for moms who are unable to stop in pregnancy, getting them connected to some type of nicotine replacement or medication to, focus on tobacco treatment, smoking cessation after their baby is born is really helpful. So again, nicotine of importance is that it's one of the higher persistence rates. It's really hard to quit. People who've used a number of different substances, experienced all types of addiction, will often talk about how nicotine is one of the hardest quits. So alcohol use in pregnancy, about 10% of pregnant women report current alcohol use and 5% report current binge drinking. Part of this is because people who persist in use in pregnancy are more likely to have a use disorder compared to the general population. If you don't have a use disorder, you find out you're pregnant, you quit, no big deal. If you do have a use disorder, you find out you're pregnant, you're going to have a harder time stopping because of the use disorder. So binge drinking is higher risk. All drinking, though, is leads to risk for fetal alcohol spectrum disorders, FASD, and that includes a wide variety of different diagnoses. I have them bullet pointed here. So the most severe is fetal alcohol syndrome, FAS. This is where you're going to have someone who might have permanent intellectual disabilities, permanent changes to their facial features, permanent changes to cognition, motor learning. That's going to be the most severe. And FAS is, of course, more common in really extreme drinking. I've had people ask, can you get FAS from one drink? The likelihood of that happening is incredibly low. The current thinking is that fetal alcohol spectrum disorders, that there is an epigenetic component, however. So if the fetus has the genetic, basically, predisposition to an FASD, and then alcohol is introduced in the pregnancy, that can turn the gene on. However, for most of these diagnoses, including some of the more general blanket diagnoses where a child is having developmental behavioral problems, we know that there was alcohol use in pregnancy. So then they might get a diagnosis called this neurobehavioral disorder associated with prenatal alcohol exposure. There has to be the minimum amount of exposure that in order to diagnosis, and one drink in pregnancy is not the amount of alcohol that that someone has to drink in order to, or be exposed to get this diagnosis. However, because of the lifelong adverse impact to children, the recommendation from the Surgeon General and CDC and all public health bodies is that there is no safe level of alcohol use in pregnancy. There is a dose effect relationship. So again, as soon as, I'm just going to put it this way, starting with one drink in pregnancy and going up, the risk goes up. So it's not like a flat line until you hit one drink a day and then it goes up. It starts going up immediately. And so, one of the things, again, when we're working with patients who are using MAT or in any type of substance use treatment, especially when the precipitating substance was an illicit drug, there's sometimes mixed feelings about stopping alcohol use and whether alcohol is a drug and et cetera. Patients on the fact that even if you might resume alcohol use after delivery for the safety of the infant. And I've heard parents who drink throughout pregnancy and are so stressed about the possibility of it adversely impacting the child that they can't even enjoy the glass of wine. So, definitely wanting to counsel your patients on the potential risks. And you also might have patients who themselves have those effects of prenatal substance exposure. And I'm going to show you here what that looks like. So here we have a graphic indicating the impact, again, of this dose-response relationship. Unexposed infants and the likelihood of aggressive behavior in early childhood, age 6 to 7. Non-exposed, significantly lower than even low or moderate heavy. The range is larger for moderate heavy, meaning you could have some children who have really aggressive behavior, whereas with low, tempered. But the same thing is true with delinquent behavior. There's less of an effect on thought problems, but other types of consequences of prenatal alcohol exposure that your clients themselves may be dealing with that were the result of them being exposed when they were babies include having a really difficult time with emotion regulation, difficulty with making decisions, difficulty with what we call adaptive behaviors. So these are life skill behaviors, taking care of bills, taking care of your finances, taking care of your property. People with fetal alcohol spectrum disorders might also have challenges with peers, trouble reading nonverbal signals, behaving in a way that is developmentally inappropriate, so acting kind of younger than their age and therefore struggling to connect with peers their age. So we could do a whole separate session on this, but I think it can be illuminating for people who are struggling with things. Maybe they've gotten an ADHD diagnosis or an autism diagnosis. The standard therapies aren't working very well, and people often don't consider prenatal substance exposure. And that's a huge driver and often a misdiagnosis when it comes to ASD and ADHD. All right, so cannabis in pregnancy, about 5% of women report current cannabis use. Cannabis persistence rates are similar to nicotine, which is mind-blowing. So the percentage of people who persist in alcohol use in pregnancy is something like 10%, and it's closer to 50% for both cannabis and nicotine. Part of that is the reasons people persist in nicotine use. It's super available. I think the public health messaging on alcohol being unsafe has resulted in more people changing behavior. Where science is that there are no effects to the baby due to cannabis exposure, or the science is inconclusive, which I'm going to push back on that in a second, because we actually have a lot of really good, very strong studies showing that cannabis exposure does result in many of the same outcomes that alcohol exposure does, including low birth weight, small for gestational age, preterm delivery, NICU stays, and SIDS, as well as longer-term behavioral and cognitive outcomes. Like with all of these substances, there is a dose-response relationship. But again, if you're someone who persists in use in pregnancy, you're more likely to be using more to begin with and have a harder time stopping. So here's a graphic from a study that came out in JAMA that looks at the effect of cannabis exposure on the likelihood of adverse pregnancy outcomes. And each of these bars is a very specific level of THC. This is the lower end, and this is the higher end of THC. There's more babies who have lower levels of exposure. But as you can see, there is a clear relationship where the higher levels of exposure result in, increasing levels of adverse pregnancy outcomes. This is cannabis exposure just during the first trimester. So even heavy levels of cannabis exposure early in pregnancy, followed by cessation, can result in adverse outcomes at the birth event. And then this is cannabis exposure throughout the duration of pregnancy. And again, for people who persist longer, they're more likely to use more because they possibly have cannabis use disorder, et cetera. So we have more folks over here on the higher end, and similarly, more adverse effects at the birth event. And this includes things, again, like low birth weight, small for gestational age, having to go to the NICU, et cetera. Looking a little further out, we have a really, really rigorous study right now that's happening nationally. It's called the ABCD study, and it's looking at prenatal cannabis exposure and childhood outcomes prospectively. So one of the critiques of a lot of studies on cannabis exposure is that, well, if you find people who are connected to a psychiatrist and then ask how many of them had prenatal cannabis exposure looking backwards, you're not going to get a true understanding of risk, because you're not measuring the people who had cannabis exposure and didn't need psychiatric care. So this study is prospective. It's starting with a birth cohort and looking forward, measuring cannabis use along the way. And this study looked at infants who had no exposure, infants who had exposure before the mom found out she was pregnant, and infants who had exposure after mom found out she was pregnant. So presumably the pre-knowledge exposure, first of all, happens early in pregnancy and is lower amounts of exposure, and yet we see increased effects on internalizing problems in children, thought problems, social problems, externalizing problems, attention, lower cognition, and lower birth weight. So again, I think especially in the recovery community, especially when we're thinking about harm reduction, which is life-saving and amazing, and we want to meet people where they're at, but we can downplay the effects of, like, we want to just work on the most serious substance first, and that is totally valid. And cannabis and nicotine and alcohol can cause some lifelong problems for the baby. We don't want to say this to scare parents. We want to think about this in treatment planning. I just want this in your back pocket when you're working with parents, when you're working on pregnancy prevention, when you're working on counseling patients during their pregnancy, that when it feels appropriate in the context of your clinical relationship and your clinical decision-making, that you know that cannabis is not without long-term impact and very rigorous research on the infant into childhood. So this has become increasingly common everywhere, including in Connecticut, but using illegal stimulants, mainly methamphetamine, also cocaine in pregnancy. 5% of pregnant people, again, report using illicit drugs, excluding cannabis, and this would include methamphetamine and cocaine. The National Survey on Drug Use and Health does not specifically measure meth and cocaine use right now. They have at different periods of time. Mainly, they used to measure meth when the meth epidemic in like the early 2000s, and they've stopped doing that specifically and focused on opioids. But nonetheless, we know that rates are increasing, and they're often in polysubstance use situations. These stimulants can trigger preterm labor, restrict fetal growth, increase stress on the baby, low birth weight, small for gestational age, NICU stays, cognitive problems in childhood. I think there's less debate around the potential adverse impact of illegal drugs on the pregnancy compared to cannabis, nicotine, and alcohol. And really, I think cannabis is the one that people are most unaware of the literature today. But as you would expect, using illegal stimulants in pregnancy has, produces problems for the child during the neonatal period, including toddler age and in primary school age. And this harkens back to the research that came out during the crack cocaine epidemic and all of the sensationalized media. And there were these articles that were like, we have an entire generation that are about to start kindergarten and they're ruined because of their prenatal substance exposure, cocaine, crack cocaine specifically. And of course, that is overblown. Know that there's something along the lines of post-acute withdrawal syndrome, which it also happens in babies. So it's going to take a couple of years after the substance use stops for their brain and cognition to heal from the substance use. We also know that there are environmental factors that play a really big role in development, and a parent who's in a position where they're using methamphetamine or cocaine in pregnancy, the circumstances of their life are likely creating risk for children as well that contributes to developmental outcomes. But even piecing all of that apart, we do see increased risks in kids. There are some kids who, are totally fine. Again, there's a dose response relationship. A little bit less is more. So if you have a patient who's really struggling to stop, celebrate moderating, celebrate using less, because overall, the less exposure, the better, whatever the exposure is. And you may, again, if you have patients who themselves had prenatal substance exposure when they were in utero, helping them understand how some of the challenges that they're facing now as adults could have to do with that exposure. And there are specific therapies that can help them overcome those challenges that, are not going to respond to the therapies that are traditionally used for ADHD and autism spectrum disorder. Okay, now we're going to talk about opioids in pregnancy, and this is going to be, again, the focus of a lot of our look at MAT. So opioid use in pregnancy, as you saw on one of my first slides, is much, much, much less common than other types of substance use. Of course, it's way more common than it was 20 years ago, and that's why people pay attention to it. It's also very lethal. So unlike some other substances, including methamphetamine and cocaine, you don't have the same rates of overdose deaths, fatalities, and neonatal abstinence syndrome withdrawals in the infant than you do with opioids. So because folks with opioid use disorder are so much more likely to end up in the healthcare system for very high acuity conditions, it has become a focus of, national attention, national conversation. And even though it's overall a much smaller population than other types of substance use in pregnancy. So we do know that opioid use in pregnancy can be, especially unmanaged, untreated opioid use disorder, can result in preterm birth, growth restrictions, longer-term impacts on cognition, motor functioning, development, and behavior. I'm going to talk in a little bit about the difference in those longer-term impacts between an unprescribed opioid, a street opioid, and a medication for opioid use disorder used appropriately. And of course, with all of these, there's a dose effect relationship. All right, so we have effects here on and school due to any type of prenatal opioid exposure. So it was not only street opioids, but we see that, and this is from a meta-analysis. So this is looking at multiple different studies and samples to understand the effects of prenatal opioid exposure on, again, these outcomes at different timeframes. And as you can see, so each of these bars is a study, a separate study with a separate population and a separate sample. But nonetheless, you can see that across studies, we see more struggles among infants up to 2 who have prenatal opioid exposure. And this is specifically looking at cognitive and motor outcomes, preschool age as well. And then we have a few studies that have looked at school age difficulties. I was part of a study that looked at the association between prenatal opioid exposure and the need for special education services in childhood, and found a significant relationship. And that, of course, included infants who'd had exposure to MAT. We also see a lot of concern around NAS and how that has changed over time. But as you know, as you well know, there are huge differences regionally, and how this is changing over time regionally. So the chart on the left here shows all of the states and the cases of NAS in 2020 per 1,000 births. West Virginia has remained in the top for much of the epidemic. Connecticut is right here, kind of top third, 21 per 1,000 births in 2020. So not at the very top, certainly below some of our neighbors, Vermont, New Hampshire, Pennsylvania, Massachusetts, but still up there. Some of these Midwestern states, like where I am now in 2020, had really low rates of NAS. But we see that the rates have increased considerably. So even if a state has lower rates, here's South Dakota, they were at 6.6 per 1,000. Their rate over the preceding 4 years increased over 100%. So this is a moving target. And as we're in what's now considered the 4th wave of the opioid epidemic, where polysubstance use with opioids, fentanyl and methamphetamines, fentanyl and cocaine, fentanyl and xylazine, is the, primary public health concern. But we're also seeing just more opioid use across different parts of the country. So because there are risks associated with opioid use in pregnancy, we love medication for opioid use disorder. It is FDA approved, the gold standard, using medications that, combined with counseling and behavioral therapies, treat opioid use disorders, one of the most fatal types of substance use disorders that we deal with. The goal, of course, with MAT is to provide a whole patient approach, meaning that we're not just writing a script and sending them out the door. We're working on building their recovery capital. They're primarily used for opioid use disorder, but as I mentioned, you can use MAT for alcohol use disorder, for nicotine. There's some clinical trials right now looking at the impact of buprenorphine, Wellbutrin, bupropion on methamphetamine. So, there continue to be clinical trials and research looking at how we can expand our arsenal here. These medications reduce illicit drug use, so much safer to use, preventing overdose, improving social functioning, and increasing treatment retention. And these benefits are true in pregnancy as well. Preventing relapse, keeping a pregnancy stable, improving outcomes for mom and baby, can be, in many cases, safer for mom and baby than stopping opioids suddenly. Reducing illicit opioid use, which is where we can have concerns around the quality, purity of the product that someone's getting off the street. Again, preventing overdose, improving engagement in prenatal care, and increasing chances of recovery. So if you have a patient who has an opioid use disorder, an MAT is the standard of care. This includes pregnant patients who've been in active addiction before they find out they're pregnant. You can induce MAT during pregnancy safely and improve the likelihood of all of these outcomes for that patient. You can continue patients on MAT who've been successful on MAT in the past into and through their pregnancy. So many different benefits. You all, again, being in the field, probably very aware of this. The three most common medications for MAT: methadone, a full opioid agonist; buprenorphine, a partial agonist; and naltrexone is an opioid antagonist. They each work differently, but they all reduce cravings and relapse. And of course, we have the buprenorphine naltrexone combination that, buprenorphine naloxone combination that helps build in a safety mechanism as well to work with patients who are dealing with an opioid use disorder. So I'm going to spend a little bit of time now talking about methadone versus buprenorphine in pregnancy. There are pros and cons, and as you're working with your patients who are on one or the other, I just want to equip you with this knowledge so that you can counsel patients. Okay, I see a hand. Darcy, are there questions that we should pause and
I do
cover?
not have any questions. Heather, you may have come on late. The chat is disabled. Please, you could either, you could put your question in the Q&A and I will get it to Dr. Sieger that way. Does that work?
Yeah, that would be great.
Okay. Thank you.
And please, Darcy, feel free to interrupt me if we need to clarify on anything. Okay, so the debate in which medication is better for pregnancy has most to do with looking at two different outcomes, and the literature goes in different directions on these outcomes. The outcomes are treatment retention and severity of NAS. So obviously we want to retain everyone in treatment, and we want as little or as least severe NAS as possible. And unfortunately, the literature goes in opposite directions on that. So I'm going to, again, tell you about all this literature, and you're going to have to use it in the context of your clinical judgment, your patient's preferences, et cetera, to help make a decision. So methadone is an incredible medication. It can be inconvenient depending on where your patient is in recovery, because at the beginning of treatment, that person is going to have to probably make daily visits to the clinic for dosing. It is safe in pregnancy, results in, again, all of those amazing benefits that I just talked about: fewer overdoses, more retention in prenatal care, more retention in treatment, et cetera. But compared to buprenorphine, can be associated with more significant infant withdrawals in terms of NAS. which can be very distressing for the parent. We're going to talk more about NAS in a minute here. Buprenorphine, aka Suboxone, Subutex, etc. Now that the X waiver has been removed, anyone with a license can write a buprenorphine prescription. Not everyone will, and that's also kind of a barrier. But you don't have to be in a special prescribing class in order to write buprenorphine prescriptions anymore. They also are beneficial because there is a lower overdose risk with buprenorphine compared to methadone. There's more of a risk of diversion with methadone compared to buprenorphine. And buprenorphine also is associated with milder NAS in the infant and a shorter hospital stay. So some pros and cons. Again, we're going to talk more about this in a second. Okay, so methadone is a full opioid agonist. It binds to the opioid receptor just like an illegal opioid does, but it has a longer half-life. It's a steadier experience for the patient. Again, binds really well to that receptor and produces less of the roller coaster of high and sick that an illicit opioid would cause. I've also heard anecdotally that buprenorphine sometimes isn't enough for patients who are coming off really high doses of fentanyl. And for those patients, they might not have enough cessation of craving and withdrawal with any dose of buprenorphine and will prefer methadone. It, again, has to be given in specialized clinics. So many incredible benefits, but depending on the patient, if that patient has heart problems, they might not be a good candidate for methadone. It can interact with other medications, and for a patient who, for whom buprenorphine might be a better option because of the concerns around neonatal abstinence syndrome. So again, I think many of the, if not most of the folks on this call are at Root Center, so you probably know this, but in pregnancy, a patient is going to have to receive daily dosing. They might have been in recovery for a long time and be on carries and only be coming in once every week or every 2 weeks, but their dose needs are going to change over the course of the pregnancy as the pregnancy impacts their metabolism. And so often providers will bring a patient in more frequently as you're working through those dosing changes. Certainly, if someone is being inducted on methadone, already pregnant, there's going to need to be a higher level of fetal monitoring, maternal monitoring, again, because of the potential impacts to the heart of both the fetus and the mother. The ideal situation with any MAT is that there is team communication and team approach. And we're going to talk about family care plans in a minute, but family care plans are a fantastic way to support this team approach. We want to have releases of information executed so that methadone can talk to OB, can talk to social work, can talk to pediatrics, so that everyone is on the same page, because things go awry at the birth event when people are not all on the same page. Providers in different settings may not have sufficient knowledge about methadone, may have preconceptions, stigma, etc. around methadone. And so the best approach is to get everyone on the same page as early as possible and be in a lot of communication. All right, buprenorphine is a partial opioid agonist, so it's going to just block a proportion of the opioid receptors in the brain, making that opioid less effective, which is why it prevents overdose and is, again, a very helpful harm reduction approach. It does have to be prescribed in office settings. I say trained providers here, but it doesn't need to be someone with an X waiver anymore. That was ended during the Biden administration. And buprenorphine can be filled at a pharmacy. So for patients who need that convenience, who have more recovery capital in the community, who maybe have a less severe substance use disorder, someone for whom methadone is inappropriate from a medical perspective, buprenorphine is an incredible option. Again, it's so much more flexible, easier to access, et cetera. One of the downsides of removing the X waiver, though, is that therapy is no longer a requirement to receive buprenorphine, unlike methadone. So methadone now, in order to be a part of an treatment program, the patient has to participate in some type of therapy in addition to the methadone. That used to also be the case with buprenorphine, recognizing that the whole person approach is the most effective way to treat any substance use disorder, including in the context of MAT. And when the X waiver was removed, they were like, well, we're not going to make your like PCP figure out how to do a Suboxone group. So they did away with the requirement and subsequent reimbursement for those groups or that therapeutic approach. So that has been definitely a downside and requires clinicians to think more creatively and to get patients connected kind of their own accord and their own motivation, which can be a challenge. Okay,
Dr.
so again,
Sieger,
yes.
sorry to interrupt, but we did
No
have a
problem.
question come through, and Heather is wondering about breastfed babies and mom being on methadone. She had a client who was on 83 milligrams, and the doctor stated that the baby was being affected by her methadone and put in the NICU to monitor.
Yeah, we'll talk about NAS in a minute, and breastfeeding. Those are both amazing questions. The likelihood that a baby gets NAS is not a 1-for-1. So it's not like we can predict based on the dose that a baby will develop NAS or the severity of the NAS. So it's certainly possible that the baby did need to be treated in the NICU, but NICUs should also be baby friendly, meaning pro breastfeeding. And unless a patient is also using street drugs, using a breastfeeding while using methadone is absolutely indicated, totally supportive, totally beneficial to the infant's withdrawals. So we'll talk a little bit more about that in a minute, but I'm glad you brought that up because I want to emphasize that when we get to those slides. And that sounds like one of those horror stories where you have a provider who is just not up on the literature, not educated, and also part of why having this team approach in place early so that releases of information are in place so that advocacy can happen on the treatment side to work with providers on the hospital side should something like that happen where there are concerns about the safety of breastfeeding. Okay, so buprenorphine, Suboxone, Subutex, amazing. Not all providers are comfortable prescribing. Addiction psychiatry is a phenomenal resource for providers who know all the ins and outs of Suboxone prescribing. Some patients, again, might not stabilize as well versus methadone. It really depends on what's going on with the patient, their history, their drug of choice, their just all the different factors that you would take into account, including the patient's preferences. And we have a lot of evidence that it's safe and beneficial in pregnancy, but it's a newer medication compared to methadone, which has been around for over 50 years. So we have a little bit less evidence. So I talked about the impact on NAS, but there are some other factors that suggest that buprenorphine can be preferable if you're in a situation where a patient is a good candidate for either, meaning in terms of their kind of recovery profile, their addiction profile, they're really go either way. In that situation, you probably want to lead buprenorphine because there's a lot of literature that birth weight is less affected with buprenorphine. Babies are larger if they're buprenorphine exposed versus methadone exposed. And I don't even want to put it that way. Like if a patient is using buprenorphine or versus methadone, if a patient is on buprenorphine, their babies tend to be larger than moms who are on methadone while they're pregnant. We also have less prematurity with buprenorphine compared to methadone, although not with every study, and the effects are a little bit more tempered with that. And again, with NAS, we have some pretty good literature that the severity of NAS, which again, this is one of those things where the language is evolving. So neonatal abstinence syndrome, I'm going to talk more about this in a sec, but is now often called NOWS, neonatal opioid withdrawal syndrome, because that's specifically in regards to withdrawals due to opioid exposure. So the flip side of this coin, though, is that there is some evidence there's more treatment. I think this has a lot to do with the types of patients. So if you have a patient who's been on methadone for 10 years and you have a patient who's been on buprenorphine for 10 years, they're not the patients who are going to discontinue just because they get pregnant. This is for folks who are in untreated opioid use disorder, get pregnant, present for treatment, and then are given either buprenorphine or methadone. And in those cases, the treatment discontinuation rates are higher for particularly Suboxone, the preparation that includes naloxone, compared to methadone. That's this bottom graph here. And we want to see, so if the two lines overlap, there's no significant difference between the outcomes. And then if the lines differ, there is a significant outcome. We want to see a higher line. So the higher the line is on this graph, the more likely they are to remain in treatment. And we see, more treatment discontinuation, more people leaving treatment compared to the methadone group after, relative to days after initiation. But by, later in the pregnancy, even the buprenorphine group is going to be discontinued more frequently than the methadone group. Again, this is for a subset of patients who are in untreated use disorder before they find out they're pregnant and then are initiated during pregnancy. So for this group, methadone does appear to be the preferred medication. And so now we're going to talk a little bit about unplanned pregnancy and tapering, because I think this is often missing from the conversation because we love MAT so much. It's so great that I think, and there's so much fear about overdose, so much valid fear about overdose. There's so many bad outcomes that people are aware of either anecdotally or with the literature, that if someone with an opioid use disorder presents for treatment, it's almost like that is the only way we're going to go. And yet there are many pathways to recovery, and we want to support patients in their autonomy and in pursuing the pathway of recovery that is right for them at the time they're at in their recovery. So tapering is gradual reduction of medication dose that is sometimes considered by patients in pregnancy. It is discouraged due to high relapse and overdose risk. This is particularly true, though, if it is an unplanned pregnancy and if it's someone early in recovery. So if you have someone who has been, again, out on the street, they come in, they find out they're pregnant, they come in, they want to get on MAT, they're on methadone for like 2 weeks, and then they're like, I want to taper. That is the patient for whom we have so much evidence that that patient is at very high risk of relapse and subsequent overdose, that if you're going to support that taper, you need to be working on that recovery capital in a major way. If you have someone who has been stable on their Suboxone for years, they find out they're pregnant and they want to talk about tapering, that's a very different situation. And I think people are quick to just throw this, like, we want to discourage taper because of this overdose risk, but you really need to consider it in the context of that patient and their recovery. Again, because of the fact that that baby, there are some risks associated with MAT. When we're comparing it to life or death, then the life or death is always going to win out. But there are some effects in NAS, and then those longer term effects on cognition, motor, vision. There's all sorts of stuff that can happen to a kiddo, even with MAT exposure in the long term. And so a patient who is aware of those risks has sufficient recovery capital to consider a taper should be supported in that taper. Again, in the context of your clinical judgment and what's going on with their recovery. But that is an uncommon scenario. Many pregnancies are unplanned. And I love Connecticut has this rolled out, and you all are probably already using it, but I love it so much. I want to talk about it every time I have people listening, which is the intervention one key question, which the idea is that we embed pregnancy planning and prevention into every setting, not just your OB appointment. And that the key question, the one key question is, would you like to become pregnant in the next year? And the idea here again is that we're asking this question in treatment at the WIC office, at your primary care provider office, at your psychiatry visit, that we're asking it in a lot of places, not so that you can then start doing much. The rest of the intervention is simple and often involves referrals, but just so you can begin the conversation. Based on the answer that the patient provides, you then do some other things. So if the patient says, yes, I definitely want to become pregnant in the next year, that's when you can start saying, okay, we need to then talk about, like, how are you in your recovery? Are you interested in discussing a taper? Are you on prenatal vitamins? Where are you with nutrition, exercise? Where are you with nicotine? Where are you with cannabis, alcohol, all of these other health behaviors? And working with them to set things up for success. If the person says no, then the focus is on ensuring satisfaction with their current contraception and promoting, if not educating, long active reversible contraception like IUDs and emergency contraception. Because again, if someone is new in recovery, they're getting their feet stable, they're, adding a newborn into that equation is just a lot to handle. So the more we for a planned pregnancy, the better. And again, if someone says, oh, I'm kind of open either way, then you kind of work with both. Okay, let's get you ready. Should you become pregnant? Should you decide on a random Tuesday that today's the day you want to get pregnant? Let's make sure you're all good for that. You're taking your prenatals, you're as healthy as possible. And let's make sure you have access to Plan B. So if you wake up Wednesday morning and you realize, no, that's not what I want to do, you have support in ensuring that you do not become pregnant. And we know from some research that pilot studies with one key question in there's satisfaction and improvement in pregnancy intention screening. Women are open and receptive to the intervention. There's increased use of contraception, and providers are also reporting better ability not only to identify pregnancy intention, but pregnancy ambivalence due to relationship problems, including IPV, mental health, and substance use. So someone might say, well, I really do want to become pregnant, but my boyfriend gets, I don't know, he's always really hot-headed. I'd be nervous, if I were to get pregnant. And then you can take next steps around that. Again, because you're in an ongoing clinical relationship with your patients, you maybe already know a lot of this stuff, but it's just something to consider and add to your practice portfolio if you think it would be helpful. So again, I've talked about this already. There are lots of risks to tapering, particularly for certain populations, but the universal approach to screening taper is also ill-advised and doesn't take into account the risks to the baby, and the mother's preferences. So again, things to just keep in your back pocket. Okay, so now I'm going to focus on NAS versus NOWS. We're going to get into breastfeeding, what the difference is, how to best support them, and then we will, I think, get to And there was an article that came out in Pediatrics now like 4 or 5 years ago that introduced NOWS as the term for opioid withdrawal. Both NAS and NOWS characterize these withdrawal and neurobehavioral difficulties in substance-exposed newborns that can happen secondary to a range of exposures: nicotine, alcohol, cannabis, cocaine, methamphetamines, PCP, opioids. Babies exposed to any of these can be fussy, jittery, sleepy, rigid, have difficulty feeding, difficulty sleeping. But if you have a baby who's exposed to alcohol, cocaine, PCP, you can't give that baby alcohol, cocaine, PCP to treat those withdrawals, but you can with opioids. So the biggest difference is that it comes down to NOWS is the only form that can be treated with an opioid or another type of sedative. All the other ones are going to have to be managed through non-pharmacological approaches, which I'll talk about in a second. I also want to say I showed you that graph earlier with these rates of NAS and how they vary across the country and go up and everything. And we don't want withdrawal if we can prevent it, but it is not always a bad thing because MAT can result in NOWS and NAS. But more importantly, we have moms staying in treatment. We have reduced rates of preterm birth. We have larger birth weight. We have better birth outcomes on so many metrics. And when we have a baby who's super preemie due to like an untreated opioid use disorder, heavy opioid exposure, those teeny tiny preemies don't demonstrate NOWS symptoms. So if you have a mom who is on MAT, on MOUD, their baby is longer term, better cooked. They have a better cooked baby. They're gestate longer, the baby's larger. That baby then is more likely to experience NAS or NOWS than that teeny tiny preemie who had heavy fentanyl exposure, but that's a better outcome. So again, the media, we often portray NAS as a bad thing, but it can also mean that we have a healthier baby who's going to go through this short-term experience. But all in all, we have a baby who, again, has so many other benefits. And in fact, it's a great thing compared to a baby being born at 24 weeks and not demonstrating NAS or NOWS, but they're dealing with all the other consequences and problems that come along with being a 24-weeker. So NOWS is likely, again, and this is something you do want to talk to parents about because I think parents can feel blindsided if they are not counseled sufficiently on what to expect and how to support their babies. So a baby is going to need to be observed for at least 72 hours after delivery when there's no chronic opioid exposure for the development of withdrawal. And this would also include pain patients. So this isn't going to be you had a surgery, you broke a bone, you had to have a surgery and you took, Vicodin for 5 days in your first trimester. That's not the 72-hour monitoring. This is for opioid exposure throughout the pregnancy. It does depend on the type of exposure as well in terms of monitoring. So for your methadone patients, the baby's probably going to need to be monitored for 5 to 7 days. Ideally, mom and baby are in the room together. They're recovering. They're in mom and baby unit. There's no separation, but there's going to need to be that longer monitoring to see if NAS symptoms are going to emerge, and if so, the level of severity. And the severity matters because of the question that Heather pointed out, which was, are they going to need to go to the NICU and get pharmacology, meaning they're going to need to be treated with morphine or methadone or some other type of, usually it's some type of opioid, or if they can stay with mom and use these non-pharmacological approaches. And now I think all of the hospitals in Connecticut use an approach to assessing the severity of NOWS that is called Eat, Sleep, Console. The old assessment was called Finnegan. Finnegan used 21 signs and symptoms, many of which were not unique to NOWS and were highly subjective, that would send more babies to the NICU for pharmacology, result in a very slow taper and a very long time in the NICU. Now that we've switched to this new approach that prioritizes a functional assessment, which is, can a baby eat an ounce, sleep for an hour, and be consoled within 10 minutes? If those three things can happen, then baby gets to stay with mom, and then you work on these supportive interventions like creating a low stimulation environment, swaddling skin to skin, and breastfeeding. And this environment helps to ease the infant's discomfort of the withdrawal, but in a way that doesn't require NICU or pharmacology, and also result in the family leaving the hospital much, much earlier. So the specific symptoms that you look for in NOWS, again, I told you that Finnegan scale is assessing 21 different symptoms. These are the most common symptoms, including irritability, trouble sleeping, GI difficulties, and nervous system activation, all of which make it difficult to eat, sleep, and be consoled. And so if you assess those three functional behaviors or tasks of the infant, you're able to get a good idea about the severity of the NOWS and whether this is a baby who's going to be okay being comforted with mom, or is going to need that pharmacological taper to prevent more severe withdrawals like seizures, and things like that. You know, losing tons of weight because they can't eat, and health risks associated with not sleeping. So when you're prepping mom for delivery, you want to let her know that some babies are going to possibly stay in the hospital longer, that monitoring is totally normal, that comfort care, swaddling skin to skin, rocking, and asking the nurse, the social worker, asking for help in understanding, especially if this is a first-time mom. I didn't know how to do a swaddle. That's super hard, especially with a baby who's in withdrawal. So getting help in providing this comfort care, absolutely supporting breastfeeding. That said, breastfeeding is hard if you have a baby who isn't dealing with withdrawals. So making sure that mom knows that fed is best. Of course, we want to support breastfeeding, but if the baby's withdrawals are interfering with breast, a baby can learn how to breastfeed after leaving the hospital. And the most important thing is that in those early days, you're able to ensure feeding, get through that really acute period of NAS, and keep working on breastfeeding. The clock never ends. My son was in the NICU, and we didn't figure out how to breastfeed till he was a month old. And I was pumping in between that, and we supplemented. So there's just so many different pathways. And we also want to make sure and advocate for our patients. If you have a provider who's saying breastfeeding isn't appropriate because mom's on methadone, that we make sure to advocate for that patient and inform the provider that breastfeeding is absolutely indicated, really important to supporting the baby's recovery and encouraging that bonding and attachment and all those benefits. So we want to support that. So babies do better when mom is actively involved in caring for the baby during NAS. And it's going to also give that mom confidence, because NAS isn't going to stop when the baby leaves the hospital. NAS symptoms can persist for 6 months, and then we have post-acute withdrawal symptoms that can persist for a couple of years. So we don't want to scare mom, but we want to normalize that things that you're seeing in your newborn or in your 2-month-old or in your 4-month-old does not mean that your baby is broken. It does not mean that your baby is going to be struggling for their entire life, and to ask for support and help to, again, give that mom confidence in caring for their baby. Before the baby discharges from the hospital, there need to be no clinical signs of withdrawal for 24 to 48 hours. Lots of patient education, including around NOWS and routine newborn care. We need that 2-day follow-up to the pediatrician. Every baby in Connecticut who has an NAS or NOWS diagnosis is eligible for birth to 3. and should be getting a referral. So if that, even if they don't go into the NICU. So if if the pediatrician at the hospital hasn't made that recommendation or made that referral, then the mom should know to ask her pediatrician for that referral. Home nurse visitation, also incredible. 0 to 3 in Connecticut is amazing. There's so many resources. We also want to do some additional testing and follow-up because of certain conditions that are more common in this population, including Hep C. Plans of safe care coordinating with child welfare is appropriate. And then DBP referral as appropriate. That's going to be handled more by early intervention, but certainly in communication with pediatrician. So this brings us to our discussion on family care plans and how Connecticut handles prenatal substance exposure, including MAT exposure. And I'm now currently leading a 5-year study funded by the National Institute of Drug Abuse on Connecticut's captive family care plan policy. And I'll show you in a second, but statewide, there've been a reduction in CPS referrals at the time of birth involving infants with prenatal substance exposure and a reduction in out-of-home placements for that population. I mean, we're continuing to, and I'm interested in talking to anyone on the ground who's doing family care plans about your experience, how it's helping, hurting, making no difference. We're really just trying to gather information. So in Connecticut, substance use is identified either in pregnancy or at delivery, and at the time that substance use is identified, a family care plan should be developed. Now, I know you have situations where, again, it might not be the right time the minute the substance use is identified to be like, okay, now we're doing a family care plan. You might want to wait a few appointments, do it at the 20-week, let's make sure we get through the first trimester. No need to develop a family care plan if there's going to be, an adverse experience with the pregnancy. But again, we want to get it in place as early as possible that makes sense so that people are communicating and on the same page. Mom is prepared, hospital is prepared, etc. At the birth event, and you want to educate mom on this, the provider, it's usually the social worker, it's sometimes the nurse, is going to submit what's called a notification, a CAPTA notification to DCF. That notification excludes any identifying information, but the social worker is going to be asked 2 questions. 1, are there concerns that the parent's substance use could impact their parental functioning? And 2, if there are other concerns around abuse or neglect. If they answer yes to either of those questions, then they're going to be prompted to make a referral using normal, a hotline to DCF, a 136. If not, then the notification, the family gets their family care plan, goes on their way, and receives services in the community. If they answer yes, the family care plan then becomes part of their work with DCF. Although not every referral that happens through this mechanism gets screened in. And even if it does get screened in, our data show that the likelihood that that baby is going to go in out-of-home placement has declined over time. So what is a family care plan and what should it do? So I already talked about the de-identified notification. That family care plan serves a few purposes. It helps identify unmet needs, not just for mom, not just for baby, but both at the same time. And for your patients who are becoming parents, they are now dealing with themselves as adults, as women, as people, for themselves as a person in recovery, and now a parent. And we have an infant who not only is a new baby, but is possibly dealing with some withdrawal, some additional health care needs beyond that of a typical newborn. And often substance use disorder is occurring in a context of other risks and needs that this family care plan can help identify, keep it all in one place, and help case manage, help get people on the same page. Again, with some of these patients, they're connected to 15 different prescribers and organizations and agencies. And this is a way to get everyone on the same page working together outside of the context of the child welfare system. When appropriate. So this is data from the first 4 years of CAPTA implementation in Connecticut, and this shows the type of substance that was included in the notification. This is looking at single and poly substance is right here. And then this is any type of exposure. I'm going to talk through this. So close to 70% of notifications in the state of Connecticut, cannabis was the only substance identified on the notification. So again, most people who are using substances in pregnancy, it's cannabis or alcohol. Although alcohol, you'll see this is only 1% of notifications identified alcohol. And that is because unless someone shows up to deliver drunk, it's unlikely that the provider is going to identify alcohol, unfortunately, given all that I've talked about. About 16% have multiple substances, any combination of these other substances, and then much smaller percentages of notifications involve, what we consider hard drugs and then other prescriptions, including prescription opioids, 2 types of MAT, and prescription benzodiazepines. When we look at any type of exposure, either as alone or in combination with other substances, it's close to 80% involve cannabis, 21% include any opioid, and 14% include any either methadone or buprenorphine. So overall, again, a little over 14% include medications for opioid use disorder. And I want to add that polysubstance is the 4th weight of the opioid epidemic. It's also at highest risk of a DCF referral. And the more substances, the more likely they are to get a referral, regardless of what that combination of substances is. And we have some data that methadone patients are more likely to have that polysubstance compared to buprenorphine patients. I would love to hear your thoughts on this. I think it might have to do with the fact that methadone patients are sometimes earlier in recovery. So if you do a meconium test, they are going to have substances maybe they're not actively using. They're also maybe in a different stage of change. And so using methadone to deal with the opioids, but are not in any type of recovery around other types of substances. So because of this, methadone patients are probably a little more likely to get a referral, again, because of the relationship between a polysubstance exposure and the likelihood of a referral. I want to add this to you guys working in MAT in Connecticut is that getting a prenatal family care plan is most common for, and that's what this blue bar shows. This is getting a prenatal family care plan. The yellow is the postnatal family care plan developed at the time of delivery. And patients who are on MAT and using it appropriately, meaning no other substances, are the most likely to get a prenatal family care plan of anyone in the state. So major props to you guys. That is incredible. Prescriptions are more likely to get that family care plan at the time of delivery. And then again, some of these other substances are less likely to get a family care plan ever. And a lot of that has to do with the fact that there's a safety concern. There's going to be a referral to DCF. And so at least at the time this data came out, which things have changed since that time, now there's more emphasis on doing a family care plan at the hospital, even if there is a safety concern. But early in the implementation, we think that folks were just like, we're making a DCF referral. We're not going to go through the rigmarole of doing a family care plan if DCF is going to take the case. So just a little aside there. Family care plans, the way the data are captured in Connecticut, capture 27 different service needs. And ideally, of course, we want 100% of family care plans to talk about safe sleep, postpartum depression, breastfeeding. But the way the data were collected at the time, it wasn't clear if this is something that needs to be addressed. This was something that's already addressed, et cetera. So because of that, the data are a little difficult to interpret. But my main takeaway here is that most of this has to do with being a new parent, which is fantastic. And of course, for patients who are untreated, need more connection to resources and substance use supports, that's great. But a lot of what you're doing with a family care plan is getting them ready to be a parent in recovery. And of course, we want to make sure they stay connected to treatment, but also equipping them to be a safe and consistent caregiver. just again, to ease any concerns that your patients might have about getting a referral to child welfare, this chart right here shows of these substance types, and substance type is the biggest predictor of outcomes, controlling for the race ethnicity of the mom and controlling for the mom's age. It really boils down to what the substance is. And the dark blue bar is the percentage that get diverted, that get that blind notification in the family care plan in the community. And then the yellow and the lighter blue, kind of cobalt blue lines are a plan of safe care with a referral. And then this is no plan of safe care and a referral. So you see these prescriptions, MOUD and prescription benzodiazepine, prescription opioids are most likely to have that diverted. And these data are a little older. I imagine this number has gone up because at the beginning of the implementation, if there was no family care plan, that family was an automatic referral. Now that's not the case. The hospital is just going to be told, look, you need to make a family care plan, but it's not going to tell them you need to refer to CPS or to DCF. So I bet this number has gone up, but the majority of MOUD patients, MAP patients, are getting services in the community. And of course, there are going to be MAP patients who need a DCF and who at least need that connection to services that DCF can connect to in a safety plan and things like that. It certainly does not mean that there's going to be a removal, foster care involvement, et cetera. Like I said, at a systems level, we've seen a significant decline in the proportion of these infants who get a removal over time, even among the more severe cases. The families that are most likely to get a referral are where there's illegal drug use or polysubstance. So again, for those patients who are in super early recovery, preparing them for, DCF is likely going to show up. That does not mean you're going to lose your baby. The best thing we can do is be proactive. We want to get you as stable in recovery as possible. We want to identify safe people in your life. We want to get safe housing. I know that one is like so hard, but also very critical, at least consistent, safe, consistent housing, even if it's like you're staying on your sister's couch, but if you have a safe place to put baby, and you can show that mom has been staying there for a while, it's not a plan that you came up with the day before she went into labor, you're going to ease worries that this is a situation that could result in a worst case scenario. Although I will say that safe sleep issues often are in a couch or a chair. So if you have a mom who is couch surfing, I think the recommendation that like baby is always on their back, separate from mom, is insane as a mother. Like, who can do that? You're getting no sleep. But making sure that if you are going to sleep next to baby, put a blanket on the floor. The crevices of couches and easy chairs are really dangerous spots. So finding a place that's equally uncomfortable for you and baby to sleep, at least you can do it together. All right, so last point here, key takeaways. MAT is an amazing medication. NAS NOWS is absolutely treatable, but you are going to want to make some recommendations to your patients in the context of where they're at in recovery, what their recovery supports are, what their recovery capital is like, what their patient preferences are, because there are some pros and cons to buprenorphine versus methadone. We also want to make sure that we're enveloping that mom in support. A family care plan is an incredible way to do that. Root Center, I know, has their own family care plan. So if you're connected to that organization and you aren't aware of the family care plan that Root uses, they use a phenomenal family care plan. One of the challenges with family care plans that are developed in pregnancy is getting that family care plan to the hospital at the time of delivery. So that's why executing those ROIs, getting that family care plan in the mom's medical record for her OB, so that when she shows up to deliver, there's notes all over the place. Mom has a family care plan. Here's where you find it. She might not bring it with her because when your water breaks, you might not be like, my family care plan. So making sure that those ROIs are in place so that everyone's on the same page can not only help prevent child welfare, referral and removal, can just set family up for success. So that is all I have. I know we're close on time. I do want to answer some questions if We have a couple. Darcy?
We have nothing yet, but I'm going to give
Oh,
folks
okay.
a little bit of time.
Yeah, no problem. Like I said, you can email me, find me on TikTok. I love engaging. However, I know, on a webinar, it can be hard to come up with questions, so no pressure. But I hope to be a resource if you all have any questions. I know you're doing the good work on the ground in Connecticut, and you all are really leading the way. I mean, Connecticut is a lighthouse for the country on how to do collaborative care, collaborative supportive care for patients who have substance use in pregnancy and moms who are on MAT. I get asked all the time about what you're doing. We've published some studies in pretty high profile venues highlighting the great work you're doing. So keep it up, and I just appreciate your time and attention.
Any questions for Dr. Sieger? We got one on. Could we please see the QR code again for TikTok?
Yes.
This has been very
absolutely.
informative and relevant.
I'm so glad. All right, one sec. Yeah, there's, as I'm sure you all know, there's so much interesting stuff out there on treatment and on child welfare casework, and I just love people who put their stuff out there. So I try to do my little tiny part again for my incredibly niche, for all 10 of us who are obsessed with this stuff, but would love to interact. And if there's any specific research topics you're interested in, let me know. I take audience requests to cover different topics.
Thank you so much.
Thanks for having me.
Enjoy the
Have a
rest
good
of your day.
everyone. You too.
Take
Bye.
care.